Good morning, good afternoon, good evening to some of you, and welcome everyone to today's webinar, Shaping the Future of Spiritual Care, Insights from Australia. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are all delighted you could join us. Some housekeeping instructions off the top. This webinar is being recorded. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit text question for our presenter by typing your questions into the questions box of the control panel that's located at the side of your screen. You may send in your questions at any time during the presentation. We will collect these and hope to include them during a Q&A session at the end of the presentation. With that, I'd like to introduce Transforming Chaplaincy former director and current senior advisor, Dr. George Fichette.
Thanks, Andy. Let me join Andy in saying welcome to everybody. Good day to our colleagues in Australia who are joining us bright and early in the morning, and hello to our colleagues here in North America who are joining us this afternoon. It's my pleasure to introduce today's presenter. Dr. Cheryl Holmes has had extensive training and professional experience in healthcare, spiritual care, organizational change, and management. Cheryl began employment as a speech pathologist before moving into spiritual care positions at state and national levels. She was appointed the Chief Executive Officer to the Spiritual Health Association in 2002. Cheryl completed a master's degree in 2014, which was focused on management and leadership, and recently a PhD exploring the narratives shaping the future of spiritual care in Australian public hospitals, and that work will be the focus of her presentation today. Cheryl was awarded the Order of Australia Medal for her spiritual care roles in the healthcare sector on Australia Day in 2015. As I said, Cheryl is the Chief Executive Officer for Spiritual Health Australia. It's an organization that many of you will not be familiar with, but during her presentation today, I'm sure we'll learn a lot more about it. From their website, it says Spiritual Health Australia is the peak body. Cheryl, that's a term we don't use here in the States, so you have to explain it to us in a minute. It's the peak body for spiritual care in the health sector. The focus of Spiritual Health Australia is on advocacy for and promotion of compassionate, person-centered spiritual care in health services. Since 1974, the organization has been collaborating with health services, faith communities, and other key partners and stakeholders to expand the availability and accessibility of spiritual care as an integral part of quality health care. I've been following the work of Spiritual Health Australia for many years, and I really want to recommend the organization to you. The website, spiritualhealth.org.au, is a place where there are really important resources for spiritual care. A number of years ago, Cheryl and her colleagues published an important review of research about spiritual care. There's an important white paper on certification for spiritual care providers. And some of you will know that along with colleagues in New Zealand, Spiritual Health Australia did a scoping review for elements of best practice for spiritual care and healthcare, and Transforming Chaplaincy was pleased to have Cheryl and her colleague Richard Egan from New Zealand do a webinar for us about that important scoping review. Cheryl, I think I first met you probably at the International Congress on Pastoral Care and Counseling in 2011 in New Zealand. And then we've met each other on a number of other occasions. I've had the opportunity to be down that way, and you came up in 2017 and joined us for the first Chaplain Research Summer Camp that we had here in Chicago. And I have to say, it's just been a pleasure to get to know you and to learn from you and to hear about the important work that you have been leading around spiritual care in Australia. And so, friends, I want to say it's my pleasure to introduce you to Cheryl Holmes, one of the world's leaders in spiritual care and healthcare, a valued friend and colleague. And I'm just really delighted that you're here today to share the webinar with us, Cheryl. So please, welcome.
Thank you so much, George. Thank you for that introduction, and I'm very moved by that. It's been such a joy and a privilege to work alongside you over the years and to learn from you over the years. Yes, with all that you have offered to the sector. So thank you for being such an amazing teacher. Good morning, afternoon to all of you joining us today. It is such a pleasure to be with you. And as we do here in Australia, I want to begin by acknowledging that I am speaking to you from the sacred lands of the Wurundjeri people of the Kulin Nations here in Australia. And I pay my respect to elders past and present, and to any First Nations peoples who may be joining us today. I'm really pleased to be with you to share some of the learnings from my recently completed, and it was just awarded in June 2023, so it's very recent, my PhD on shaping the future of spiritual care in Australian public hospitals. And I'm hoping I'm going to share my screen with you. So here's what I'm planning to cover over the time we have together today. Much has been written.
Cheryl, the slides haven't advanced. I'm not sure if you've tried to advance it.
Is that working?
Not yet. Andy,
Okay.
correct me if I'm wrong. Yeah, start over again and we'll be good.
Is that working?
No, 1 second.
Okay.
We'll get it right.
Okay.
Andy, do you need to tell Cheryl what to do here?
That's it.
No, we were
Here we are.
all set.
That's it now.
There we go. Yep, perfect.
Okay. Oh, there's always one of those, even when you've practiced and you think you've got it right. Here we go. So, much has been written about the role of the researcher and the increasing importance of locating the researcher's voice, recognising that it's impossible to truly be 100% objective. Before I tell you more about the research, it's important that you know a little bit about what's shaped the lens I see through. I began working in health, as George said, as a speech pathologist nearly 40 years ago, although I don't like to admit that too quickly. I've always been interested in what it means to be voiceless and the ways in which one finds a voice. The move from speech pathology to spiritual care was motivated in part by the work with people's stories and the lost opportunities I observed for holistic care. As a child, I was involved in the Anglican Church, and attention to spirituality, my own and others, has always been an important aspect of my life. As I became professionally involved in spiritual care, I also pursued ordination, as that was still the means and identified path towards legitimacy and credibility in spiritual care. Over the years, it was people's life stories and the experiences of how people make and create meaning that began to widen my perspectives on faith, spirituality, and the nature of spiritual care. There was also something within this about the validity of each person's experience and voice that enabled me to continue to validate my own experience and spiritual identity. My role within spiritual health provided opportunities to further expand my thinking and experience about my own identity, but also about developments in spiritual care and the very slow progress towards acceptance and inclusion within healthcare. My shifting spiritual perspectives led to my leaving the church and to identifying as a cultural Christian and Anglican. My own sense that knowledge is not limited and that there is always more to be known fits with the methodological approach adopted for this research. Voice remains a significant area of interest. Whose voice is heard? Who remains voiceless? Who and what have been the influences for change? Romanchin, in his book, The Wounded Researcher, says, in this complex relation between researcher and the topic, there lingers the weight of history that waits to be spoken. As the Chief Executive Officer for what was then Spiritual Health Victoria, I'm already familiar with much of the story and have participated in that story as it has unfolded since 1999. So in gathering data and building the story of the organisation, I acknowledge that my own story and perspectives are entangled in the telling and in the meaning making that flows from the story. It was actually the desire to add my voice to the field of spiritual care through publications that provided the motivation to undertake this research. And before we really get underway, I want to introduce my team at what is now known as the Spiritual Health Association. You'll see me there. Next to me is Jenny Greenham, who is our mental health leader. Joey Go, our administrative assistant, is in the middle. Alicia Stafford stands next to her. She's our communications leader. And then we have Craig Exum on the end, who is our quality and advocacy leader. So together, we continue to lead the integration of safe and high quality spiritual care in healthcare. And that is what a peak body, we use the term peak body in Australia to mean an organisation that takes a lead in advocating around a particular cause or a professional group. So a little bit about Australia, just to give you the context for the research, and you'll see I've overlaid Australia here in the red over the North America. In Australia, the population is nearly 26 million as compared to, I think, around 330 million in the US. I come from the state of Victoria, which you'll see on your screen down the bottom, the right-hand corner, just above Tasmania. And we have just over 6 million people in the state of Victoria. Probably like all of you, we're seeing increasing religious diversity and an increase in those who nominate no religion. There are growing numbers of people who identify as spiritual but not religious. The no religion group has been the biggest cohort. It became the biggest cohort in Australia for the first time in the Australian census in 2016. And as you can see, in 2021, this has continued to grow. And further research has shown that the spiritual but not religious numbers are hidden in the Christianity figures. My role as the CEO for what is now known as Spiritual Health Association, SHA, requires vigilance to the opportunities for the inclusion and development of spiritual care in the health sector. However, creating a vision for the future requires knowledge of the past, ensuring that we neither make the same mistakes nor reinvent the wheel. And we also need a deep understanding of and immersion in the current context. I've heard it said that we study the past to understand the present. We understand the present to guide the future. For nearly 30 years, I've been involved in spiritual care in the Australian context. And over 2 of those decades, as George said, I've been leading at either state or national levels. Over this time, we've seen a growing body of evidence and research across the field internationally. While changes have occurred, we remain a long way from having spiritual care integrated in hospitals and spirituality acknowledged as an integral component of health and well-being for all Australians. We felt a new approach was needed, and it was my hope that the outcomes of my study would provide insight into the factors and influences that have shaped spiritual care over the past decades and inform future planning for the inclusion of spiritual care in public hospitals. Further, it was hoped that these understandings and insights might have application for the inclusion of spiritual care and integration of spirituality in hospitals and other health settings in Australia and internationally. So my research questions you can see here, I wanted to look at the inclusion, how the inclusion of spiritual care had changed since the mid-20th century, what the influences for change were, and how those answers to those questions could guide future planning. So, as with all research, I commenced with a literature review which looked at these 3 areas. And I thought the definitions were really important because there's been a lot written, and so many articles begin with trying to talk about how they're defining spirituality and spiritual care. Many of you will be familiar with Puchalski's definition of spirituality from the 2013 International Consensus Conference. And then the definition of spiritual care. These definitions use the language of the Puchalski spirituality definitions, and they also use the language of the spiritual care intervention codes that we have here in Australia, the ICD-10 Australian Modification Spiritual Care Intervention Codes. So the language of assessment, counselling, support and ritual. And then you'll see the ways in which we've used the Puchalski language in these definitions as well. I had a brief look at the evidence for the benefits of spiritual care and how the models have changed. Some international perspectives looking specifically at whether those who have tracked histories in other places around the world have identified any of the influences that have led to change. It's clear from the stories told in the literature, and you'll see here a number of them that I looked at, that models of spiritual care have changed since the early decades of the 20th century. The literature provides the story of a professional group who have consistently responded to external drivers to try and stay relevant. These external drivers have included, but aren't limited to, things like in the UK, the establishment of the National Health Service, across the board, increasing bureaucracies, financial pressures, increasing diversity with decreasing religious affiliation, the spirituality and health movement in the States, and the need for evidence-based practice. In response, the professional associations have been adopting the language, accountabilities, frameworks, and methods of healthcare to establish their distinct professional identity, how they fit, and how they contribute and add value. The spiritual care profession has changed in reaction to these external drivers, and it's often been the leadership and advocacy by the professional associations at the forefront of these changes. And this is frequently led by strategic visionaries in the field, such as our George Fischette. Yet the models of spiritual care on the ground continue to vary considerably, and there remains a lack of clarity about professional identity and role. The stories of spiritual care in a number of countries and those of specific professional associations demonstrate the significance given to reflection on the past to inform future directions. My literature review also covered research in Australia, which was to provide the local context for this study. We grasp our lives in a narrative. In order to have a sense of who we are, we have to have a notion of how we have become and of where we are going. I really like that quote, and it provides a great basis for my study. The study blends a narrative case study method to identify and explore the influences for change in the inclusion of spiritual care in Victorian public hospitals. There's a great alignment between narrative inquiry's focus on meaning making from experiences and stories and the focus on listening and meaning making in the field and practice of spiritual care. Both narrative and case study research methods have extensive interdisciplinary approaches and applications, and both methods can give attention to history, the chronology of events, and the general learnings, themes, or assertions formed from the analysis. Case study research is a qualitative method involving the exploration of a real-life contemporary bound system, that's a case, over time through detailed in-depth data collection involving multiple sources of information, and it reports a case description and case themes. The literature tells us case study is recognised as a way to unravel the complexity of one demarcated entity. Case studies build on actual practices and experience, and therefore can be linked to action, and their insights contribute to changing practice, which is exactly what I wanted. So the research is divided into 3 phases, as you'll see here. Phase 1 developed the case study of Spiritual Health Victoria and analysed the case holistically, the whole case. Phase 2 took one of the identified issues from the case study and completed an embedded analysis to see if the findings could be confirmed. And finally, phase 3 looked at whether the findings from phase 1 and 2 could actually be applied at the national level. The narrative of Spiritual Health Victoria was developed through gathering and reading of the organisational archives, so minutes of meetings, letters, annual reports, all those exciting sorts of documents that make great bedtime reading. And you'll see here from the archives a great photo of a gathering of chaplains in the 1970s. I believe this is a group of Anglican chaplains. Alongside all of that organisational archives, I conducted 17 semi-structured in-depth interviews with people who were past committee members of SHV, also hospital executives and government personnel. Detailed notes from the organisational documents, together with the transcripts of the narrative interviews, formed the raw data for analysis. The process of analysis enabled a detailed description of the case to be constructed, including an organisational history with a chronology of events. As suggested in the literature, the writing of the story was an important part of the analysis process. The resulting case study of SHV used the structure which was outlined by someone called Stake in 1995. The structure begins with an opening vignette to invite the reader into the heart or essence of why this case study is important, followed by an introduction to the case study that progresses to the extensive narrative description which forms a major part of the case study. As you can see in this slide, the case study is broken into 4 time periods designated by the changing name of the organisation over time. The emergent issues from the case are then identified and explored, and arising questions and areas for further research identified. The case study concludes by identifying the key influences and enablers for change. This section delivers the most important element from undertaking the case study. It's where we take the assertions or patterns or explanations or general lessons learned. And a closing vignette brings the reader back to the experience at the heart of the case study. So 3 emergent issues were identified through the holistic analysis of the case study with corresponding questions, and it will be interesting to see how these resonate with you. Funding, of course, is always an ongoing issue. Who pays and what do they pay for? For us, there was a lot of conversations around whether it's church funded or hospital funded or government funded. One of the interviews commented, and the funding formula sort of was a denominational approach, which inclined towards denominational responsibilities and so on, which moves towards the sort of pastoral care for parishioners rather than spiritual care for all comers. Then we have models of spiritual care. So how do we know what's best practice? How do we develop best practice? How do we show the value for spiritual care? And who are the providers? What does the workforce look like? We see in the models of spiritual care in the case study the shift from chaplaincy, the language of chaplaincy and chaplains, to the language of pastoral care, and then to the language of spiritual care. As one of the interviewees said, we're on a journey to change how we deliver our services and care, which is a combination of in the hospital and outside of the hospital. And we need to take spiritual support and leadership on that journey as well. So I think historically we've gone from a sort of individual, probably not so connected spiritual care to a connected care, more a part of the clinical care team, part of the support of the staff team. And now the next challenge is how do we manage the new transition, which will be beyond the walls of the hospital. And that was one of the hospital executives who made that statement. And finally, we have education pathways. There's always been a recognition of the need for specialist training, which began with CPE in the 1960s here in Australia. One of my interviewees said, that's really the part of the story, I suppose, that I can see now. Changes all seem to depend on the possibility of people having some appropriate training. And I think it was quite vital that I was able to do CPE training. Really, it was enormously important and beneficial learning how to relate to people better, how to listen, how to care. Now, the thing is that as the role has changed, the spiritual care role, in response to the growing complexity of healthcare and the increasing integration as part of multidisciplinary teams within healthcare, it seems that the training has not kept pace. Norman Denzin introduced turning points as a method of narrative analysis, looking for those tensions or interruptions or transitions that occur at moments of pivotal change. So it was finding these turning points, those tensions within the story that enabled identification of the influences for change. And again, interested to see how these resonate with you. Some of the influences for change, 4 key ones: cooperation amongst stakeholders. So whether that was through significant key seminars, consultations, meetings, or conferences, it was the bringing together of key stakeholders for dialogue around the emerging issues of the time that's proved crucial for significant changes to occur. An essential aspect of this has been the input from a diverse range of voices and the participation of people with authority to make decisions and to act on them, or at least the capacity to influence the decision, funding, and policy makers. The voice of those receiving spiritual care appears to have been missing from past gatherings, and this omission needs to be corrected in any future meetings. Attention to evidence. So through its history, leaders within the field of spiritual care and within our organisation have been influenced by what's been happening outside of Australia. From the beginning, the scoping of international models has brought new ideas and possibilities into the Australian context. Together with attention to the literature and the latest research, this has brought changes to our models of care and education and training practices. Fostering international collegial connections has enabled collaborative work that has influenced across countries and contributed to the growing body of evidence. And we still see that today. It's a really important opportunity for us. Investment, another influence for change. And of course, it's inevitable that changes were made possible through significant investment, whether that came through churches, government, or health services at different times across the history of the development of spiritual care and of our organisation. Funding obviously supports change and innovation, and over the years has enabled provision of spiritual care. Investment has supported the expansion of spiritual care and increased the influence of our organisation at local, national, and international levels. And then we have leadership and advocacy. From the early 1950s to my own role over the last 2 decades, leadership has been a key influence for bringing about change. Leadership in the narrative is demonstrated by a preparedness to be influenced, to learn, and to influence. Leaders have been informed through their attention to the evidence and through deep listening to all stakeholders. Leadership and advocacy have occurred through appointed leaders and through the professional organisations over the years, with significant leadership and advocacy from Spiritual Health Victoria. This has encouraged the other influences for change, which is why the arrows are going to each of those, and also led to development across the sector. So phase 2 of the study design had 2 aims. I wanted in this study to demonstrate that the extensive case study could inform future developments and identify research opportunities when applied to a specific issue. And then I also wanted to test that the conclusions drawn from the holistic analysis of the case study could be supported through an embedded analysis of one of the emergent issues. So I chose models of spiritual care as that issue to look at in more depth and focus specifically on the workforce issues, addressing the question, who are the providers of spiritual care? You'll see here there's been a couple of publications from that were part of my thesis, and you can find those papers. I'm happy to share those papers. It did show that we were able to look at when patients, so the article, Is There a Role for Faith Communities, concludes with key questions for the future. So I was able to demonstrate that the case study did inform future developments and was able to identify research opportunities. And the second publication addressed the question of providers with a focus on the professional spiritual care workforce. The article concluded with a call for governments and health service management across Australia to endorse and recognise qualified and credentialed spiritual care practitioners as health professionals in response to growing evidence. And then in phase 3, again, a couple of papers were published relating to this. I wanted to demonstrate that the Victorian findings, so looking specifically at what happened within the Victorian context, could be supported and applied at the national level. And again, these two publications. The first article shows that the emergent issues identified in the Victorian case study are also expressed at the national level by a broad range of stakeholders from across the health sector. And the second article went back to data from a national consensus conference to demonstrate that the influences for change can be applied at the national level and produce change. Not surprisingly, the same issues were being addressed at the conference in 2017. Models of spiritual care, funding issues, and what do education pathways need to look like. I want to look a little more closely at the issues of models of spiritual care. The questions raised in this research: how can we develop, co-design best practice models for spiritual care? How can we measure, demonstrate the contribution of spiritual care? And who are the providers of spiritual care? As outlined in the literature review, the issues of models has been explored by researchers across a number of countries and shows movement towards an interprofessional, holistic model of care. The model shown here aligns with this movement and was supported by our National Consensus Conference outcomes, as described in that Towards National Consensus article. As can be seen here, the proposed model addresses the workforce issue, supporting an interprofessional model of care in line with the generalist specialist spiritual care models advocated in the literature, and I'm sure many of you will be familiar with that. And the model also clearly specifies the role of faith representatives, which has been a crucial issue for us here. This model was first published by Spiritual Health Victoria in 2014 as part of an education package for the aged care sector, and was incorporated into the National Guidelines for Spiritual Care in Aged Care, published by Meaningful Ageing Australia in 2016. The model has not been adopted broadly in healthcare here in Australia, and it brings us to the question of how to develop or co-design models of care that can be agreed and adopted nationally. Co-design, which has also been described as participatory design, is a method that actively attempts to involve all stakeholders in the process of design to ensure results are founded on community needs while also identifying any constraints. The National Consensus Conference described in my study provides an example of a co-design process that brought together a range of stakeholders. You'll remember that's one of the influences for change, and incorporated all of the other influences for change, demonstrating an impact at the national level. There have been ongoing developments, obviously, since the Consensus Conference was held in 2017, including new evidence-based resources developed by Spiritual Health Association. The proposed model, together with this proposed model, together with new resources, new evidence, the spiritual care intervention codes we have in Australia, we need an updated evidence brief. All of that new research, bringing together all of those things, could be used to inform a new co-design process using those 4 key influences for change as strategic levers. In the introduction to my thesis, I raised the importance of asking the questions, whose voice is heard and whose voice is missing? Challenging assumptions or unconscious biases is not possible if the most dominant voices continue to frame the narrative. My case study shows the dominant voice of faith communities, especially the Christian churches. That's not a criticism, given it is the historical reality of where spiritual care has originated here in Australia and in other countries, as I outlined in my lit review. The challenge for the future is to recognise the changes that have occurred and to incorporate the voices that have been largely missing up to this point. I've noted the absence of the consumer voice in the case study, and including this voice, along with identifying and including other voices missing in the narrative, will be essential to co-designing a model for spiritual care that can be agreed and implemented nationally. In our context, this will mean the voices of First Nations people must be included, given the importance of their spirituality that's recognised and acknowledged across our health policies. Yet their voice is missing from my case study. In addition, attention needs to be given to the diverse voices representative of the Australian communities, inclusive of religious, non-religious, and spiritual viewpoints, and taking into account other signifiers of diversity, such as ethnicity, ability, and gender. To my knowledge, my thesis brings together for the first time the issues and questions needing to be addressed in the Australian healthcare context and identifies the influences for change that can be used as strategic levers to shape the future of spiritual care in Australian public hospitals. All through undertaking the research, there has been an interplay between my work as CEO of the organisation and the study. The thesis was undertaken over 6.5 years, so of course that dance and interplay was ongoing throughout those years. There have been opportunities for the ongoing integration of the research findings to inform the work of the organisation. A project to co-design a contemporary and consistent national model for spiritual care in Australia commenced in 2022, and this has been directly influenced by the findings from this study. SHA has provided leadership and advocacy in the initiation of the project as the professional body. As George mentioned, a joint literature review was undertaken with colleagues from New Zealand to ensure the project gives attention to current evidence. Cooperation among stakeholders was a key dimension of the project, and there were opportunities for attendance at workshops and participation in surveys and interviews. Investment has been identified as a required outcome that will be given due consideration through the project, with stakeholders invited to identify barriers to the implementation of the model and to develop solutions to these barriers. It's anticipated that the outcomes from this project will continue to shape spiritual care in Australian public hospitals in the future. We have now co-designed a national model for spiritual care and it is currently being piloted and evaluated across 11 health services in Australia. So for international colleagues and all of you in other contexts, I invite you to think about these questions. How will the provision and enactment of spirituality and spiritual care be different in your context? As you consider the history of spiritual care in your own context, what have been the influences for change? Whose voices have been dominant and whose voices missing in your narratives of spiritual care? And what are the turning points occurring in your context that may become pivotal moments for change? Tensions, interruptions, transitions. Some of the tensions that I've observed, the tensions between the medical and the psychosocial spiritual models of care, the tension between religious versus spiritual care, the tension between faith community providers and the professional spiritual care workforce, the tension in professional identity, religious leaders or health professionals. COVID-19 has been a huge interrupter in our times. What's the opportunity for spiritual care at this turning point? It's been suggested by colleagues in the UK, Ewan Kelly and John Swinton, that the telos or ultimate aim of spiritual care for the 21st century is the spiritual well-being of all. How will spiritual care respond to that challenge? Attention to stories at the heart of what we do and who we are. Stories can be sources of rich learning. It's why case studies have been so important for spiritual care research, and it's why I chose a story for my thesis. It's also why in these last few minutes, and hopefully I've got time, I want to conclude with a story from one of my interviews, which tells of an encounter from a spiritual care practitioner. It's so often in connection, in relationship, where change begins. And this has the potential to transform the person and also to bring about a broader transformation. So, a story. They were in remission from brain tumours. It was after hours, as I can remember, and these guys were gathered around for their session, and I thought, oh goodness, what am I going to say here? So we talked about, well, they didn't want to ask about God. They didn't want God talk. So we sat around and I asked them, what memories do you have of moments where you were just taken out of yourselves? An event or experience that you can remember that was memorable, incredible, or wonderful. I can't remember exactly what was said, but it was just immediately captured their imagination. And one tough-looking guy said quietly that he remembered sitting on the banks of the Murray at night, watching the moon on the river with his mates. He said that he had prickles up the back of his neck. The stars were twinkling on the water, and he was with his friends. They had a line in the river and a few tinnies, a few beers. That's authentic life. What is it that you go back to find meaning and purpose, awe or wonder? It might not be that for everybody, but it was for him. And I thought, well, there were others, and they all joined in because they knew it wasn't going to be holy talk as such, but it was a shared spirituality of relationships and of a liminal experience that they could all identify with. A spirituality of the maintenance of hope through relationship, experience, and place, and a link to another frame of reference between the here and now. An individual's spiritual life is shared and brought to life through the telling of their story, and it is a gift for me to be the listener and participant at the bedside when these life stories are shared. Thank you.
Cheryl, thank you so much for sharing your really excellent, thoughtful work with us. I'm just really grateful for that. We have about 10 minutes. It's the start of the day in Australia. Actually, Cheryl has hours. Oh, sorry. So if people do have any questions, be sure to type them into the question box here. But I want to ask you to say a little bit more about the models that you developed, the framework, the models for care, your collaboration with the Meaningful Aging in Australia allowed that model to be adopted in aged care. And then you did some further co-design work, and now it's being adopted or being piloted, as you said, in
Yes.
some other agencies. So what will some of those pilots look like? Could you say more about that?
Yeah, so we've got a range of health services who are piloting. Our national model is up on our website, and one of the things about the model is that it identified 4 priority areas, which are holistic person-centered care, integrated governance, professionalised workforce, and sustainable resourcing. The exciting thing about the model is that it has a number of quality indicators under each of those priority areas. And out of that, we've developed an audit tool so that health services can actually assess themselves against those quality indicators, and have a look at the areas where they might be doing well, they might be performing in a mediocre way, or they're not meeting that quality indicator at all. So they immediately get an assessment of where they need to be putting their time and focus on really lifting up their spiritual care service. Look, I think it's been a really long journey for us, because across Australia, and I'm sure it's the same. Well, you know, I know in the States there are similar sort of inconsistencies in the way spiritual care is delivered, but we still have models that are very denominationally focused, models where it is church-appointed people who are providing the spiritual care within health services. And then we have health services where spiritual care professionals are actually employed by the health services and integrated into the multidisciplinary teams. So we sort of have this broad range of models happening. And so for us, it is about how do we, you know, as I said at the beginning, we really want to see safe and high quality spiritual care services across Australia. And even that model being integrated within national guidelines for aged care, it's inconsistent across our aged care too. So for us, it's the challenge of getting government and policymakers actually endorsing and mandating that there needs to be a standard for spiritual care in Australia.
And will that happen state by state, or even at smaller local levels?
It's at the moment it's at the smaller local levels. I think it needs to, because of the way our health system is actually structured, health does happen at a state by state level, so it is influencing the departments of health in each state. But getting national government, Commonwealth government recognition would also go a long way. I mean, the states and the government talk to each other. and they have a national health agreement. So, you know, getting the national government on board would go a long way to influencing that state-by-state movement. But the good thing about our pilots is that we have a number of the states involved in the pilot.
What did it take to find the pilot sites and get them to buy in?
So one of the ways in which Spiritual Health Association has changed over the last few years is that we used to be an organisation that only had faith community members. And then we restructured in 2019 and it became possible for other organisations to join Spiritual Health Association. So we now have quite a number of, we have around 40 members, and over half of those are health services. So it is a number of our health services who are actually put their hands up. But because the process of developing the national model was that co-design process, a lot of them were involved in the gatherings talking about the model. So there was that buy-in right from the beginning. They were part of creating it and therefore wanted to be part of piloting it.
Really, that sounds like such an important development, actually. I should, for the North American listeners, and particularly the US listeners, emphasize actually that your organization, Spiritual Health Association, we don't have anything comparable like that in the United States. You are not the chaplain membership organization in Australia,
No.
which is Spiritual Care Australia. And here in the United States, we have several. Our biggest one is Association of Professional Chaplains. But your organization, as you said earlier, the peak organization that's involved in advocacy and research and things like that, we in some sense don't have an equivalent here. That our Association of Professional Chaplains or other groups think about advocacy, but they haven't really been able to invest in it to the level that you have, and to really, particularly when you changed your membership organization and no longer were just, the faith groups, but you began to have health organizations that were members and therefore stakeholders in how this was developing.
That's right. That's right. I mean, I guess in some ways you have your own, like Transforming Chaplaincy is doing that research, and Chaplaincy Innovation Lab is doing some of that innovative work as well.
But neither of us are really into the advocacy the same way. I mean, what struck me when I looked at your thesis, was the diagram about the influencers of change and the way in which leadership and advocacy played a pivotal role in being able to kind of be the central influencer, bringing together the stakeholders, attention to evidence, trying to advance the investments in things. Because it sounds like a key piece about the implementation of the models is that actually health organizations have to invest in spiritual care in ways that they haven't in the past. That's very hard to kind of convince organizations to do, particularly when their finances are not, the budgets are always tight.
Oh yeah, and and in this particular, in the climate at the moment, I don't know what it's like for you, but for us, the expenditure throughout the pandemic, and then in response, after the pandemic, it just means that there's a tightening up all over the place, and funding is really difficult. So that the trying to actually say, so how does spiritual care contribute? And of course, they're wanting to know, how does it contribute to the bottom line? Are we saving money here, or are we generating money? And we're not generating money, but are we saving money? And that's always been the difficult question for us to answer, isn't it?
Yeah, exactly. Listen, we have one more minute. We have two questions. My colleague Mia Baumgartner in our state of Washington wants to know whether or not the quality indicators in the model are in the publication. Did they audit?
The quality indicators are in the publication, so it's sort of like a table like this.
Yeah, your publications have got such great layout as well as great information. So Mia, go to their website and look for it on models for spiritual care. And then we have a question actually from a colleague of yours, where Katie Tunks Leach is asking whether or not this will work not only in healthcare but in other settings. She's a practitioner and researcher in the first responder setting, and wonders whether or not the models for spiritual care can be considered there, advocated there.
Look, I'm really excited to look at the potential for the model. Like at the moment, obviously for us, we're looking at how does it work in health, in the health setting. And as I said, we have a range, including the Western Australian Country Health Service, which is huge, and they're looking at it across their palliative care services at the moment. So, Katie, I think there's the opportunity for us to have a conversation, and I think it would probably be really good for you just to have a look at the model and start to think about where there are points of connection with your own sector, and we'd certainly be happy to have a conversation.
Sure. Just one more question. I know we're at overtime, and folks, Marsha McDougall says it seems fine to have spiritual care providers from faith backgrounds being available to offer spiritual care to those of faith or no faith. But what are the challenges for non-faith-based spiritual care providers supporting people who have major issues concerning their faith? Does that make sense, that question?
Yeah, it does. Look, our model really takes in the whole question around workforce, and it's got this great diagram that looks at where the faith representatives fit, where the professional spiritual care fit, and that, you know, spiritual care is the responsibility of all. I think one of the really interesting questions for us is that we've always had this sense of it's okay for somebody with a faith background to offer spiritual care to everybody, but we've always had a bit of a, how can somebody without a faith background? I think, you know, I talked about our unconscious bias, and I think there are some things we need to do there, because I think if somebody is trained, qualified, credentialed as a spiritual care practitioner, if we are all offering spiritual care that is person-centered, and somebody says, I come from this faith tradition and I want someone of my own faith tradition, any spiritual care practitioner will find the person that patient needs to see. Like, that's imperative, that's the role. So I don't see any different. If I come from a Catholic background and they want an imam, I'm not going to try and be an imam, I'm going to get the imam.
Yeah. Let me just say in response to that question, Marsha, colleagues at the Chaplaincy Innovation Lab did some interviews with chaplains who identify as not religiously affiliated, humanists and other chaplains, and they published a paper about that this year or last year. The first author is Amy Lawton. Wendy Cadge is part of the team. I had a chance to scan the paper yesterday, actually, and it looks like it's actually a useful response to that question as well.
George, sorry, and can I just say, like, one of the things that we're really saying is that we have a spiritual care practitioners form the professional workforce for spiritual care. There are no labels. There are no labels. They are the spiritual care practitioners, like the social workers, like the psychologists. We don't ask about their backgrounds, and we no longer require people, this is what the model is, for people to be endorsed by any faith community. That's not part of what makes them a qualified and credentialed spiritual care practitioner. So we do have people who aren't, you know, who don't have a religious background.
That's another webinar that we should have, actually, is what's the role of faith group endorsement. You may know that on behalf of the Association of Professional Chaplains and the ACPE, Transforming Chaplaincy, actually did a study about the pros and cons of faith group endorsement in the US context, and we've presented a few workshops about that. But anyway, an important question for the profession as we move forward. Thank you so much for getting up bright and early, and thank you so much for the great work that you've done for years and years and continue to do with this fine project. We continue to look forward to learning from you and your colleagues and to collaborating with you wherever we can on this important research. Thanks so much, Cheryl. Friends, thanks for joining us today. We hope this has been helpful, and we wish you all the best. Take care.
Thanks, Cheryl. Thanks, George.
Thank you.